I think we might start at the top and just ask who would like to update us on where they're at. That looks like Ian. So go for it, Ian. Just unmute and we're all ears, nearly.
Am I okay?
Yep, sure.
Hi, look, I haven't been on for 2 or 3 years.
Oh, you're still alive, mate. You're still here. That's good.
I'm still alive. I've just celebrated my 19th anniversary of survival with metastatic prostate cancer. My PSA is 0.058. And I've never had an operation, so I've just been on hormone therapy, chemotherapy. So I'll just give you an update of how I've travelled. Probably the thing that saved me is Xtandi. I've been on that for nearly 9 years, and that is just a magic drug for me. It's just kept my PSA really low, undetectable, which I never got with Eligard, which I'm still on, and so Xtandi's been the drug for me. And I'm still on Eligard, of course, and I still have a Xgeva jab every 3 months. The other thing I've had, though, in the last few years, I picked up kidney cancer, which turned metastatic as well. So I'm running 2 metastatic cancers, but I had some radiation with that, and I had some immunotherapy, which killed it off quickly. I had some standard immunotherapy, and I reckon that's helped my prostate cancer as well. I'm having I was on immunotherapy for about 15 months, and I'm having a break at present. Still seems to be working. All my numbers are good, and immunotherapy is not supposed to work with prostate cancer, but in some small subcases it can. I haven't got any proof that it is, but I'm just thinking I'm nothing. I'm fine. Like, I'm low PSA, and all the cancer's gone out of my lung and liver, and so I'm hunky-dory. Apart from I've got a sore shoulder from playing golf, but apart from that, I'm okay.
Nice stuff.
That's right.
Yeah, that's
yeah. So yeah, 19 years. So I'm happy.
Yep, well, that's fantastic. It really is great, Ian. That's you've got such a good news story to kick things off with. So you had no primary treatment, I gather, no radiation, as well as no RP?
Initially, when I was diagnosed with Gleason 4+4 and a PSA of 24, and it spread to the bones, so I couldn't have an op. And I went on to Eligard, and that worked for a while, and then eventually it failed, and then I had a couple of second-line things that I did, a couple of years of chemo, but eventually that failed. And about 9 years ago, I got onto Xtandi, and that's killed it.
That's a really good news story.
Yeah, I guess I'm one of the long survivors. I've still got my prostate, whatever that looks like, but yeah, so I'm still functioning. Still can play golf.
I'm up in a similar league to you, although I did have an RP, but my wonder drug was, which came fractionally before Xtandi, was Zytiga. Had exactly the same long-term benefit as you've had. So we're lucky to have been born with when we were. 5-10 years before that, we'd probably been dead.
Well, that's what happened when I was originally diagnosed. Xtandi wasn't around, so chemo was the last line of defence then, but it's not anymore, and there's plenty more things, of course. So
yeah, exactly. Does anyone have any questions of Ian?
Alan, can you see that Ross Chapman has raised his hand? Can you see?
Oh, you're doing it like that. Okay, I've got to look closely. Okay, Ross, go for it, Ross.
Okay, thanks very much. I just want to ask a question. My story is quite different. I've had an RP. I've been through a couple of rounds of hormone therapy plus radiation. I'm now on hormone therapy, Leukeran plus darolutamide, and it's going well so far. I've just had a long discussion and debate with both my oncologist and dermatologist, and I've just started psoriasis medication, which is on the immune system. And my research tells me that it's going to have a similar effect to yours, Ian, that while it won't hurt, it'll actually might help for prostate cancer as well. And I had a lot of trouble convincing my dermatologist that that's the case. But the drug I've started is Tremfya, which is an interleukin that affects the immune system at that particular point. And they all say, oh, that won't affect prostate cancer, but I think it actually will. It can't hurt, and it will probably help. And I think the immunotherapy is the next frontier for prostate cancer treatment. It really is. While, as you said, Ian, they all say, oh, no, it doesn't work with prostate cancer. It actually can in certain different mechanisms. So that's my story. And as I said, just yesterday, actually, I had the first shot of Tremfya, which is first one, then 4 weeks later, then every 8 weeks, you get a single shot of this. And it's for psoriasis, which I have, but I think it will help the prostate cancer as well and work with the leukin plus darolutamide that I'm currently on. So that's just an interesting overlap with Ian's story, I think.
That's an interesting one. I can see Paul. I think you've either waved or you wanted to speak, Paul.
Yeah, great to hear your story, Ian, and everything going well. Just wondered how they picked up the kidney cancer.
Good question.
That was by a fluke, really. I was seeing my GP. I have acupuncture with my GP. He does that, and I was just complaining. I was feeling a bit unwell, and he said, "Oh, okay. Why don't you go and have an ultrasound?" And the ultrasound picked it up. Like otherwise, I would never have known. Anyway, I then went. My urologist talked to him. He says, "Oh, maybe it's not that big, so we'll just monitor for a while." So it was really by fluke that I picked it up and monitored for a couple of years, but eventually it got bigger and bigger. And then I didn't really want to have an operation, have a kidney out, even though that was probably the best decision. But I had some high density radiation at the PA hospital in Brisbane. But then on a follow-up thing, they did a scan and it had spread for whatever reason. So it spread to the liver and the lung. But the immunotherapy, I elected to have the infusions, by infusion, because I reckon if I had to go into chemotherapy again, didn't want to have 2 infusions in one go. So yeah, I think I was just lucky to pick up the kidney cancer early. I didn't have any other symptoms or anything about it. So yeah.
And it totally unrelated, or they can't tell?
Well, that was the thing. I remember seeing my original oncologist and I said, "Why did I get kidney cancer?" He said, "Oh, well, you live so long with prostate cancer, so you're just going to get kidney." I was expecting something a bit more realistic, but that's what he said. Like, you've just been survived so long, you got kidney cancer. Why I got kidney cancer? I don't know.
Well, they're certainly different cancers. They're not.
They're not. Yeah, I thought, how the hell can you get? How the hell can you get 2 stage 4 cancers? It's just ridiculous. But fortunately, I could see them. That immunotherapy, again, I think it's the new drug that we, and my oncologist who treated me for both said, "Look, I think a small subset of men it does work for, but I haven't been tested for that, and I don't care. It's not too bad. Knocked me around the first time, but when I had 2 drugs, but I'm just on a maintenance drug. Well, I'm not on any drug at present, but I have a 6 months break, so whatever, yeah."
Well,
Kidney cancer, if you're a long-term survivor, you're going to pick up something,
That's true. You're not on your own. I've got 2 cancers going, stage 4, so I've got an issue with thyroid cancer. So these things happen. The longer you live, the greater the chance.
That's right.
And do you think, and Alan and Ian, do you think because we're seeing lots of specialists and that we pick it up quicker because we're in in that advanced cancer group, we're going to see specialists a lot more, so we pick up these secondary cancers quicker?
Well, certainly the fact of high definition scans is a factor. If you have got a high definition picture of your internal organs, that they don't just look for the particular condition that was the reason for the scan. They look at everything, and in my case, it was discovered incidentally, the thyroid one, because of a scan to check the progress of treatment for the prostate mets. So it's the technology's there now, which a few years ago even wasn't there. In Ian's case, you had a doc who had a sixth sense by the sound of it. If you ordered an ultrasound just on the strength of you saying you didn't feel well, that was pretty good.
Well, he's amazing. He's a Chinese guy, and because I see him every week for acupuncture, we have about a minute discussion about things. I go to see for all sorts of other things, but that was amazing what he did. Most GPs couldn't care less. Even in my oncologist, because he was only thinking of prostate, he wasn't thinking of anything else. He didn't pick it up. Sure. But we're just seeing him for the, he's looking at one thing. Yeah.
Yep. We better move on. I've got one from Peter. Peter? Unmuted.
Thanks, Alan. My question's probably to Ross. You indicated you're on darolutamide. How long have you been on it, did you say?
Okay, on darolutamide, I've been on it since, let's see, early this year, so about March this year. So whatever that is, 7-8 months.
Right. Yep. Okay. Well, I've been on 5 different lots of hormone therapy. So I've been on the enzalutamide and Xtandi, and in June I was put onto darolutamide. At my last blood test in September, and for some reason my oncologist just gave me the blood test results because all he was interested in was the PSA. But the liver function tests were absolutely sky high. And I'm just wondering whether you have had a similar instance where they've checked your liver function test?
Not as yet, because my last blood test, the full screening blood test was about in April, just after I started it. Now I've got to have another blood test in this month. So I'll be checking it then. So your liver function test, I know which ones they are. I'll be checking those and talk to my oncologist in November.
Yeah. Well, there's 3 liver function tests that my wife's a phlebotomist, so she always has a good look at the results of all the blood tests. And generally they have a scale of 0 to 70 is the normal range. Well, in most instances, for the 3 months I was on darolutamide, instead of being 0 to 70, it was like 125.
Wow. But
the oncologist never said a thing about it. And when I've read, updated things on darolutamide, and it doesn't even reference that in the fact sheet that comes in the box of tablets, is that it can affect the liver. So I'm just wondering, why, and as in Ian's case, all they seemed to be interested in was the prostate and the PSA, whereas these novel drugs seem to have an effect on, other parts of the body.
Yeah, that's a really good point. And I think the fact that I get the same thing when you're bouncing between specialists. They each want to look at their little bit without looking at the whole part of the body, and that frustrates me no end. So I've got to be the communicator between the specialists to get them talking. When you've got things affecting you from this medication or that medication, they don't know about it.
Yeah,
that's what an empowered patient does, Peter. Ross.
Yeah. Well,
if you're educated enough to look at your test results and understand at least in principle what they mean, you can ask questions, and that's a good thing to do.
Yeah, I've had a pain in my neck now for a month. I went to my GP because I didn't want something to be in there and then all of a sudden it goes up and I have a stroke or I have a heart attack. And he's checked out the vascular part of it, and he referred me to have an ultrasound done to see what was going on. But when you read the fine print on darolutamide, it actually says contact your doctor immediately if you have pain, and it lists all the various things, and one of them is the neck. But when they prescribe these medications, they don't tend to give you as much information as possible. And it's only from me chipping away on the internet to find out these things. So I'm still waiting on the results. It's not something that I've lifted in the wrong way, because I've had it for 1 month and it's just in one localized spot. So you've had nothing like that at all, Ross?
No, nothing like that. I mean, I've got pretty bad neuropathy in my legs.
Oh, yeah.
And that's affecting my balance pretty badly. But I've been seeing a neurologist about that, and he reckons it's a combination of things. It's previous chemotherapy many, many years ago when I had testicular cancer, and he said it's your diet, and you have you drink alcohol, and I was going, well, 1 rum and coke at night's not too much, but all these things. I said, you know, what's causing it? No idea. So yeah, could be the drugs, could be all sorts of things.
That one in your neck, Peter, it sounds like potentially a possible lymph node that's got a bit big and causing a bit of discomfort. The reason for that, if that is what it is, is obviously various possibilities. But
well, when my GP wrote the referral for the ultrasound, he actually did a diagram of my head and neck and where he believed it was, and he said, not vascular, not glands.
Oh, yeah.
So,
well, this could be some, muscular thing. Hopefully that's all it is. Great. Okay. So does anyone else have any further contributions to make to what we've covered? If not, we'll move on to the next person who'd like to give us an update on where they're at. If you can just raise your hand if you'd like to go next. Don't all speak at once. There's one. That's Paul. Good on you, Paul. Go for it. Just unmute.
Yeah, so I've just saw my oncologist for the medical oncologist for my 3 months. Yeah, 3 months. So the PSA is down to 0.08. So it was end of July was 0.45. Oh yeah, by the way, I'm on the Xtanti, I think. Oh, sorry. I'm on the Xtanti. Yeah, and also I've got the little capsule. I just had that second one put in for that, the 3 monthly capsule, Gosrelin. Yeah, so the PSA is down from, so I was up to 22 before I started the treatment, and so now it's 0.08. So he seemed pretty happy with that, and we were happy with that. So feel pretty good, and doing plenty of gym work, and yeah, just adjusting to this new normal life. But we're off to Bali next week, and so just starting to resume normal programming.
I like your definition of normal, going to Bali. That's pretty good.
Yeah.
Do you have any primary treatment, Paul? When you
so I had the 20 radiation sessions.
Mm-hmm.
Yeah. So I got through that pretty well. So wasn't much difficulty. It's just a matter of setting yourself for a month of just not doing anything excessive and eating all the same things. So whatever works the next day, that sort of thing. Yeah, so I'm not drinking any beer. I'm just drinking red wine. So I don't know if that's
Life is definitely tough for you, I can tell. Uphill struggle.
Yeah. But I think you tend to drink less drinking red wine, so maybe that's positive. I find my appetite's very healthy, so I have to be careful. So to eat the right things. I find when I work I work from home 2 days, I go into the office 3 days. So office is, there's less temptations there. So I find that helps.
Mm.
How
old are
so
you?
everything pretty good. My wife's still, she's struggling with her response to it, but I think when she gets some good news like last week, it certainly helps. It helps her, and I'm sure a Bali holiday will help her as well.
Have you got a local support group that you are involved in at all?
No, we haven't yet. So yeah, because I remember last time you mentioned some of the options, or two sessions ago.
Well, they
So
can be really good for partners. That's what I'm thinking, because it normalises things a lot more than you might think for the partner. Because I mean, a lot of anxiety coming from there, and obviously other things have changed. Your sex life has probably changed, and all of that. So I mean, there's a lot for her to adjust to, and the more you can, together sort of work through those things, the better.
I think, definitely once we get back, that's something I'll put on my priority list, because she prioritized, she found you guys. So I'm very thankful to her for that, because this group's been fantastic.
Yeah, and she's always welcome to hook in to sit alongside you as well. Sometimes it can help.
Yeah, sure.
Yeah, partners are welcome in this group anytime.
Yeah. So so that's my last couple months.
Great, that's really good news, Paul. So hang in there with that PSA. Keep it down there.
Yes.
That combination is pretty widely used, and Zoladex and Xtandi together.
Yes.
Mixture, but
yes.
you've still got to keep an eye on it. They're not necessarily a guarantee that they'll be permanent. So there are a number of other things in the pipeline which you can graduate to down the track if you ever need to. Which again is another reason to alleviate some of the anxiety that is inevitable with this condition.
Yes.
A lot happening, huge amount happening. Okay.
Thanks, Alan.
Any questions of Paul? Any comments to make that are related? Yeah,
Alan, just to interrupt to say, person whose phone number ends in 6370. Can you say something? Tell us who you are.
This is George here.
Okay, George, be quiet now while we continue the meeting. Thanks, Alan.
Yep, I will.
Welcome aboard.
Thank you.
Think about what comment or question you might like to ask. We'll come back to you. So, nothing else on that topic? Okay, so who's next? Who'd like to give us an update on where you've got to?
Just a query to Ian. Do I remember that the drugs you were on for the kidney were Opdivo and Keytruda at the same time? Keytruda, yes, at the same time. It was some sort of trial of both, wasn't
it? It was Ipi and Nova.
Okay.
Ipi, I can't think of the names, but I did Ipi and Nova. I can't think of the brand names, but I had four infusions of those. Then I had a break, and then I went on Nevo as a maintenance drug for about 12 months. But when I had the two together, I did get knocked around for the first time, which the oncologist said, "Oh, it won't affect you compared to chemo." But it did. I went on a holiday, and it really mucked up my holiday. I was on the GAN, the train, or the Great Southern Train, and I couldn't do anything. I was buggered, It was a month before. So, but then I recovered from that. So the two together is a bit tough, but the one on its own is nothing. Yeah. So they're just the standard combination. There's a lot of options with kidney cancer, but as I said, I elected to have the infusion because in my back of my head, I thought if Xtandi fails, I might have to go back on cabazitaxel or something, and I certainly didn't want to go through chemo and immunotherapy, 2 infusions at the same time. I don't know whether anyone's done that, but that didn't sound encouraging for me. So that's why I elected to to do the infusions, and I think it was the right decision.
Yep, obviously it's helping. So those two immunotherapy drugs are complementary. They work in different ways,
Yeah.
mechanisms. So it's great that they're having such a beneficial effect for you. Yanni, you've got your hand up?
Yeah, you were asking for other volunteers to speak. So my situation is currently waiting for the latest update of blood tests, but previously I was on 0.010, and I've been on Xtandi now for about 5 years, and have recently, well, about 3 years ago, started on diferoline as the first generation support hormone treatment. But in particular, so I'm doing pretty well at the moment. But the point I particularly wanted to make is that Ian and I think Pete were making comments about secondary treatments that they're having, and that they attribute some benefit to the psoriasis drug and whatever. And I've been taking, I'm not diabetic, but I've been taking extended release metformin, 500 grams daily for the last 8 years or something. And I attribute that to, I attribute to that a lack of weight gain, and also that there, from my point of view, there haven't been any detrimental side effects. But there's recently been a report out that whilst metformin may not have that much of an advantage in low volume prostate cancer sufferers, in high volume prostate cancer sufferers, there is quite an impact. So I'd urge you guys to maybe have a look at that if you want to avoid the normal ADT side effect of weight gain.
Could be another one too, Yanni, that it inhibits the take-up of glucose, metformin, and it's glucose is pretty important fuel for cells of the body, not least rapidly reproducing cells like prostate cancer cells or any cancer cell. So that just, it's a bit like not having too much sugary or processed food. It's just the next step along that line to avoid too much fueling the prostate any more than you have to. You need glucose. You can't go off it. You need it for your brain, but it's maybe a matter of degree. Who knows? So thanks for that, Yanni. That's a good observation. So who would like to be next on the deck?
Hand up.
I think we've got Ross again. Yeah, go for it, Ross.
Thank you. Just a quick question to Yanni then. Firstly, terminology, high volume cancer. I assume that just means more extensive metastases through the body?
Yeah.
Correct? Yep, thank you. And then you talked about metformin as being a diabetes drug. So it operates in a similar way to Ozempic, I assume, does it?
I don't know how Ozempic operates, but I imagine it's Ozempic is probably a more certainly a more modern treatment, but and it's specific to diabetes sufferers, and the weight loss situation is similar too. So in some ways, I guess, but I don't know.
I've been looking because on ADT, I've been putting on a bit of weight, and because of my neuropathy in the legs, it's hard to get out there and exercise a lot, like doing lots of walking.
Yeah.
So I've been looking at something that I could use that would assist in losing a bit of weight, and that might be a way to go. Metformin.
Well, it certainly worked for me.
Yep.
And regarding neuropathy, there's a naturopath who is a pharmacist, but he has a radio show here in Melbourne, and there's a TV show as well, Gerald Quigley, and he's very frequently been recommending lipoic acid tablets for the relief of neuropathy. Now, I've not really got neuropathy, so I can't talk personally, but he's very vocal about that. Might be worth giving that a crack.
Okay. I might suggest that to my neurologist, see what he says about that. Yeah.
Thanks, Yanni.
Thank
I'll take that up too, because I've got a neuropathy problem which has not stemmed from any chemotherapy. I suspect it's due to the remaining polypharmacy that most of us guys are subject to, which is multiple medications, not necessarily for the same condition. So,
yep,
we'll have a look at that. Thanks, Jim.
For most of the last 15 years, I've been on metformin, and I followed the case all that time. I started back 15 years ago with Snuffy Myers recommending it. During that time, there have been a lot of studies, and they very clearly come in for and against. So it's not a clear case that it helps with the prostate cancer. I'm not aware of this latest one. I only gave it up in earlier this year. I went into hospital via ambulance a couple of times, and that it was because of my polypharmacy that I stopped it at that stage. But certainly I'll be looking into it. As far as the new drug, the Aussie, whatever it is.
Empic.
So my daughter's on that, and that works quite a different way. And there are some warnings attached to people who might be thinking of using it just for weight gain. That's the little I know about it. Thanks, Alan.
Thanks for that, Jim. Go for it.
So I agree, Jim. There have been quite a few different versions of it. Metformin works or it doesn't work or whatever. And indeed, as recently as about 6 months ago, there was one that came out that said there was no advantage at all, and you should discontinue it. But then only last week, I think it was, or maybe it was the week before, this other one came out that said it makes quite a difference for, as I said before, for high volume prostate cancer sufferers. I'll send you a link to it, Jim, and maybe you can.
Nev will send it out.
Yeah.
Okay. Thanks, Shani. That's helpful. I think it's something that all of us need to watch is the potential drug interactions when you're on multiple drugs. There's been a certain amount of research done when the drugs first hit the market, but there's a lot that's not known, and I think there's a good principle if you don't need something or you don't need that dosage level to try and de-intensify where you can, but clearly that's got to be done with your medical team. Okay, that's another one for Peter.
Yeah, it's to Yanni. What was the name of the drug that you spoke about for peripheral neuropathy?
It's not. It's
alternative medicine or whatever.
It's a supplement. You can buy it at chemist house. Lipoic acid. It's LIPOIC acid. It comes in tablet form.
Sometimes
capsule form.
Sometimes prefaced by the term alpha lipoic acid, just to make it complicated. Yep.
Okay.
I'm going to try it.
Thank you.
Yep. Okay. So where are we at with the next update? some of you guys we haven't heard from for a while. That's going to be Doug.
Yes, good morning. Quick update. I had surgery in October 2012, so I'm, 12-year survivor, but I've also had radiation, chemo and hormone. Still on the hormone. I haven't had a holiday from it. I'm on Zoladex. Last year I had non-Hodgkin's lymphoma and had chemo. I'm in remission on that. As I say to everyone, with all of them as good as the next blood test and examination. And now, accepting that something's going to fail somewhere. The longer it goes, the better though. And yes, I've had a bit of neuropathy from the chemo last year, and I had some acupuncture to the feet.
Oh, okay.
And that seemed, well, I believe it helped.
Right.
A little bit. And I'll probably give this lipoic acid a go too. And in September, last year, I had a Minoka, non-obstructive artery heart attack. And I'd one artery 30% and one 50%, not high enough to be stented. So, no, I've been hypertensive since age 22. So.
Oh, right. Okay. How old are you, Doug?
72. So 50 years on different blood pressure drugs and under control. Probably could be helped by losing a couple of kgs.
Yep.
But that's where I'm at.
What was the drug apart from Zoladex? What's the tablet that you're having?
Well, apart from Zoladex, I'm on my blood pressure medications.
No other anti-androgen like Xtandi?
I'm on Zoladex injection. Yeah.
Just the Zoladex?
Just the Zoladex, yes. Yeah.
So what's the PSAs doing?
Less than 0.008. Has been since 2016 after, the 6 hits of chemo. And it took a few months. It's probably 6 months for it to get down to less than 0.008.
Did you have any metastatic disease at all, or just?
I have a 2.8 millimeter in the lower left one of the lymph nodes.
You've done really well. That's fantastic.
Yeah, but it's strange. I had very low numbers, but I tripled in 4 months. Went from 0.94 to
0.094 or
0.094 to 0.38.
Yep. Well, that's worth watching because if that continues, certainly if it gets, anything above 0.5 or 0.6 or thereabouts is probably worth talking to your doc about in terms of a PSMA PET scan.
Yeah, well, that's where the 2.8, that's how that was found, with the PSMA PET back in 2015.
Okay, well, you just may need, if the PSA continues to creep up, it may not be actually creeping, even though the levels are low. If it's doubling at that sort of rate, then, sometime round about the PSA of 0.5 or even 1, probably time for another conversation. Another PET scan to see what's caused. There are half a dozen options that you've got to add.
I joined the local support group. I'm in Toowoomba. I joined the local support group the week after I was told I had at least 6. And post-surgery, I had at least 9.
Exactly. So the biopsies are highly unreliable. It's the one after surgery or
Alan, you no, can't hear you, Alan.
Oh, sorry. The a follow-up check on your Gleason score is really important. If you've got PSA running away and on a level of Gleason 6, then you have to be suspicious about the Gleason 6.
Yeah. The initial biopsy said 6, but post surgery, could have missed by, an eighth of an inch, the high grade. Yep.
Well, the fact is, it is a high grade version, and that at some point is likely to need a more aggressive response. Darolutamide, Xtandi, we've got 4 or 5 treatments that can be added to the treatment that you're getting, and as you've heard already today, they're really remarkably effective. I mean, they'll add decades to your life. That's how good they are. So,
well, in the support group, I think, through the support group, I think there's at least 5 of us who had Gleason 9s.
Yeah. Not too uncommon. Okay. Any questions of Doug that might relate to your own circumstances? It sounds like Ross, go for it.
Yeah, okay, that's really interesting, Doug, because I had a Gleason 9 score on the first biopsy. Then I had the radical prostatectomy, and my PSA has always been low, as like you, around about 0.2, but the doubling rate was really fast. So they said, okay, hit you with radiation first, plus ADT. Then it came back again, really fast doubling rate, but really low scores. They can't see anything on a PET scan, but they said, you've got cancer somewhere, so we're going to hit it. So I've been on darolutamide plus Lucrin for the last 6 to 8 months. Looks like continuing. PSA is still low, but I've got a blood test coming up this month. And I'm just, suffering through the ADT symptoms, but not too bad. My answer when people ask you is I'm still here. So that's the good news. So thanks for your story.
Thank you.
No, that's good to know. I think in your case, Ross, you may want to have a chat to your doc about a FDG PET scan as distinct from a PSMA PET scan. Not everyone has PSMA on their prostate cancer cells, therefore the scan won't work for them. And those that don't, the FDG works a bit differently. It's looking at the internal metabolism of the cancer by injecting it with a radioactive sugar, which it then tries to digest. So that may well pick up what you're not seeing on a PSMA PET, in which case that can be monitored that way. It can be treated appropriately just by upping the intensity of the treatment. So one to check.
That's great. Thanks, Alan. I'll check with the oncologist next time I see him in November about getting one of those FDG scans. I know what they are, but I haven't had one yet. So yeah.
What was your PSA when you had the last PSMA PET? Remember?
The last PSMA PET scan was
a negative one
a while ago. It showed negative. The PSA was about 0.3, 0.4 then.
Well, that's right on the edge of detectability. So I wouldn't rule out the fact that you could still be PSMA positive, but it may need a higher PSA to pick it up. I think at about 0.3, you've got about something like something around a 30 to 50% chance of detecting it. So it's not trivial, but the PSA goes up to 0.6, 0.5, 0.7, 1. Or even 2, you're up around sort of 75, 80%, 90% chance of seeing it with PSMA PET. So just keep that detectability in mind when you're talking to the doc about scans. But not everyone, not all prostate cancers are PSMA positive.
Okay, I'll do that. Thank you.
I might have been lucky. Well, I had FDG scans when I had the non-Hodgkin's lymphoma. So if they were looking at those, they might have seen if there's any additional prostate cancer hanging around.
Yeah, absolutely. Well, anything that's abnormal. I mean, the CT part of it will pick up things that are have got too big, like a lymph node or a metastasis somewhere else, a mass or a tumour that shouldn't be there. But at the end of the day, even a CT scan will do that. But the FDG part of it, which is done together with the CT, is quite good at picking up non-PSMA tumours, and they're there and can be up around 20%, 30% even of people that are not PSMA positive. That's significant. Yeah, Peter Mac, if they're doing lutetium treatment, they always do both scans to make sure that if they are PSMA positive, that they're not FDG positive, because in that case, the lutetium won't cure them. That's just a standard practice there, and I think it's not uncommon in St Vincent's in Sydney also, where they do lutetium treatment. Okay, anyone like to add anything to that conversation?
Yanni's been waving his hand for a while.
Oh, there you're right down the end of my screen, Yanni. I missed you. You got to move it like this. Then I'll see you. That's it. Now I can see you. Go for it, Yanni.
I was just going to make an observation for Doug. How are you coping with the Zoladex?
Doug, are you muted? Doug, I think you're muted. Doug, you're muted.
Yeah, I'm right now.
Okay.
Yeah.
Go for it.
Yeah. Just put up with it. It's doing the job, so that you live with that. A bit foggy. Yeah, foggy brain, etc.
Because I had it for a while, and it's a horse needle, that thing.
Yeah.
It's bigger than Ben-Hur.
Yeah.
And I've moved on to diferoline, which also comes in 3-monthly or 6-monthly depots. And Kim is also on diferoline, also known as triptorelin. And I found that to be massively more or massively less impactful on how your body reacts to it. It's a very simple jab in the bum with absolutely no side effects or anything in my instance. So you might want to just have a chat to your GP about diferoline. And from the research that I did, it was of the first generation androgen treatments, it was the most effective. So, as I say, you might want to have a chat to your GP.
Yeah, I suppose maybe naively, I'd think, well, as long as it's working, why change something? Yeah, okay, you have those side effects, but you live with it until that fails, and then you try the next one.
Yeah, fair enough. I get that.
To that, Doug.
Yes, Kim.
Almost all likelihood, all the side effects are because you're lacking testosterone, and triptorelin will do exactly the same thing, remove the testosterone. The thing is that it keeps the testosterone away. That they did a study which compared triptorelin with Zoladex, and Zoladex had more times when there was a breakout of the testosterone. That is, if it was an 84-day one, the testosterone came back before the 84th day, which is 3 months. And that was the reason that I stopped it. And when I went into hospital, the second time I went in the hospital earlier this year, the doctor there was a pretty old-fashioned kind of guy, and he wasn't responding very well to this triptorelin that he'd never heard of. had heard of Zoladex, so I had a Zoladex while I was in the hospital, and that brought a lot of things back.
All right.
Yeah,
Bloody
so-
great hospital. And since then, I've gone down to the chappie at the bottom of the hill and had triptorelin, and it's I've had mosquito bites that felt more. The thing is that it doesn't actually go in your bum. That can cause a bit of a problem in that your bum is a big muscle that you use a lot. It goes just above your bum at the side. So you've got crack. You draw a line across the top of the bum crack, and it goes above that at the side because that's it needs deep muscle, but it needs deep muscle that you're not going to use all night when you turn over or whatever.
Yeah.
Anyway, that's something to discuss with
Yeah.
you.
Okay. Yep. Thank you.
My experience is the same as Jim's and Yanni's, switching from Zoladex to diferoline. And there is some literature that confirms what Jim said. If you can alleviate the side effects a bit because of the slightly different chemical that it is, why not? You're not going to lose anything by doing it. So have a chat to your doc and just see what comes out of it.
Okay. Yep. Shall do. Thank you.
Okay. Who hasn't had a go yet? Steve, do you want to give us a bit of an update on where you've been?
Yeah, nothing much really to report. It's just.
Well, some guys won't know you, so there's always the newbies here.
Oh, look, well, I guess it's coming up to a year since my RP operation. So I guess that's a milestone.
What's the PSA doing?
Good. Well, since then, after the operation, it was 0.07 or something, but then rapidly increasing again. So then I went on the 32 dose radiation course back in March, and it's now three months after that it had dropped to 0.04, and I just had another check after the 6 months post radiation, and it was 0.02. So we're just playing the waiting game.
Yeah. It is a bit slower to get response on radiation, but as long as it's still heading south, it can take many months, even longer sometimes, for the PSA to reach its minimum. It's basically disrupting the DNA inside your cells, but it doesn't disrupt all of it simultaneously like surgery does. So you just have to be patient, keep monitoring it, and as long as it's heading in that direction, you can be pretty happy. What was the biopsy result on Gleason score? Do you remember that?
It was 9, but I don't know whether it's 4 plus 5 or 5 plus 4.
Well, it almost doesn't matter which of those it was, but that basically keeps your antenna up, obviously, to keep watching it, because it's not uncommon for higher Gleason grades to have metastasized at a micro level where you actually can't see it, and they can sit there in happily living away, and then all of a sudden decide to come out and make themselves known. So no matter what happens, you'll be tracking PSA for a while, I would say. There's no certainty that you'll get recurrence, but the odds are higher that you might. That sort of Gleason. Yeah. So steady as she goes, mate. That's good. That's a good result. We've had a few good results today, haven't we? That's another good one. I like it. Any other good news? Or any other bad news?
I'll just add a little bit to what I said about triptorelin and Zoladex. I mentioned that I wasn't terribly happy with the doctor at the hospital, The thing is that almost all of the basic hormone therapies need to be mixed. They're two-part mixtures, and the way they're mixed is very important. And triptorelin is fairly complicated. So you've got to have your doctor, a doctor that you're sure will read the instructions or will follow your reading of the instructions or watching a video on YouTube. And that was another reason that I took this Zoladex while I was in hospital, because with Zoladex, the two parts are mixed in the factory. And when the araldite has gone hard, they take a little chip of it and stick it in the horse needle. So there's no worry. So if you're stuck out in the bush or in even the mid-city and you're not sure about the doctor you've been given, or perhaps a nurse has been allowed to do the thing, then you're probably safer with Zoladex. But any one of the hormone therapies besides Zoladex, you should be familiar with how it's mixed. And it's a good idea to say, I don't want to offend you, but I like to see it mixed in for me. Yeah.
Yep. Fair enough, Jim. Thank you for that.
Never's apologised for not being able to get here. A grandson visiting his auntie left the door unlocked, and some people wandered in the middle of the night while the family were asleep, and just took the car keys and cars from underneath them. So he's dealing with locksmiths and things like that.
Yeah.
Ian Vag, I think the last time I saw you was at the Naked Turtle up at the Sunshine Coast about 5 years ago. I can't hear you. You're muted, perhaps. Ian, I'm just saying hi, Ian.
Yeah, hi. Can you hear me?
Yep.
Yeah. Naked Turtle about 100 years ago?
Yeah, it was that. I'm sure that was more than 5 years ago. It was more like 15 years ago, I think.
Yeah. And that little scooter I was on then, that a number of the people here will be familiar with, it had to go when the car went, which is why I'm, as people have remarked, why I'm learning this new mobile one. It's a super lightweight one, made of the same things as the supercars and planes and things like that. So.
Hey, Jim, I'll have to get you to send me the specs on that one. I think you sent me the ones on the old version. When you think of it, if you could email me what that one's about, what it's called. Yep.
The one I'm sitting. Oh, right.
Sorry.
Yeah.
Thank you. Okay, so we're going to be bring the curtain down soon if no one else has got anything to tell us about. Anyone who hasn't spoken that would like to give us a quick update?
Can I interrupt then, George? Are you in Brisbane or down south?
Right. Look, I'm in Brisbane, and that's why I'm late ringing in. I'm having trouble with the computer that I've got hold of to join the meeting, so I've had to use the phone.
Well, George, while you're on the do you want to tell us about what's been happening with you?
Things are pretty quiet at the moment. I'm just having Zoladex every 84 days, and PSA is less than 0.01, and that's been going now for probably 10 years, I suppose.
That's excellent.
And yeah, I'm just keeping on it. Now, earlier today, did you? Some of the boys there, did they talk about circulation to the feet, or a bit of lack of? Yeah, that's called what? Neuropathy.
Peripheral neuropathy, typically brought on by chemotherapy, but there are other things that will trigger it. And
now, what was Yanni's remedy for that? He said something from Chemist Warehouse.
Yeah, that was alpha lipoic acid, LIPOIC, lipoic acid. It's a supplement you get from places like the Chemist Warehouse. It's been around quite a long time. So if it works for Yanni, give it a go. But that's not a medical.
Yeah, lipoic acid. All right.
Yeah. Oh, I'm going to try it.
But it's
what Yanni told me.
Well, my feet are. They feel like that they haven't got the full circulation there, and it could be from the Zoladex. I did have Guillain-Barré a few years ago, and I kind of blamed that a bit, but it might not be that.
Do you get cold feet, Yanni?
No,
yeah, George. Yeah,
I don't.
I do.
I don't actually use lipoic acid because I don't have any substantial peripheral neuropathy. But as Gerard Quigley talks about it all the time to all the people who call in.
Yeah.
But correct me if I'm wrong, Al, but my understanding of peripheral neuropathy is damaged nerve endings. It's not a blood circulatory issue.
I think it's a little unclear. The blood vessels expand and contract on signals from the nerves, and if they're contracted or remain contracted, then you'll tend to get obviously cold feet. That's one consequence. In my case, they actually measure the rate at which an electrical impulse propagates down the leg, and they measure it in milliseconds. And if it's less than 50 milliseconds to get from the knee to the ankle, or some such number, then they define it as neuropathy because the nerve itself isn't transmitting fast enough. So it's not necessarily just the nerve endings; it's the whole structure of the nerves that support the limb and lower and your feet in particular. So whether the nerve issue is a secondary effect or a primary effect of what's showing up as the vasculature problems of microcapillaries and things like that not getting the flow they should. My suspicion is that if the feet are cold, and they certainly are in my case, I wear socks nearly all the time, or whether it's purely nerves only, got nothing to do with the blood flow, I don't know. I must say, looking at my feet when they're cold, they're very white, and when I have a shower, they go back to being pink again. So I'm pretty certain that there's a nerve-blood interaction there somewhere. But I'll try it. So, Peter?
Well, I've had peripheral neuropathy in my feet for a very, very long time because I've had type 2 diabetes for 20 years, but it was heightened by chemotherapy.
Yeah.
To the extent that I had to go on nerve pain medication. So I'm on Lyrica morning and night. So I will be giving this lipoic acid a try, providing it doesn't interfere with all the other chemicals that are running around in my body.
Well, there's no way to know whether they'll interfere with the other drugs that you're using either. Sometimes it's worth checking the drugs.com website because they do list a lot of interactions that occur. Maybe worth a look before you switch over. I'll do that. You may want to talk to your docs about it as well.
Well, I'm on 18 tablets a day of various things.
Exactly. That's the classic problem we all have.
Yeah.
So I definitely discuss it with your doctor and make sure that there's nothing that you haven't uncovered about it. Yeah, definitely worth it. A look though. I will do that.
You might want to try Googling Gerald Quigley, and because he is on a TV wellness show as well as 3RW's wellness show on Saturday mornings, and I believe he takes questions from the public, and going to see if you can get a perspective from him as to if it's going to be more effective or not. But Lyrica, my understanding is quite potent and quite addictive, perhaps. I'm not sure about that.
Yeah. Well, keep in touch with your medical team, which you need to do in these cases. And don't self-medicate without checking. Okay. So
it's George here again.
Yeah, George.
When I had the Guillain-Barré, I ended up with foot drop in the hospital, so they had to stick me in moon boots.
Right.
For a few weeks. So, you know, the circulation down there, just from being paralysed in hospital, wasn't all that great to my feet, and moon boots had to go on.
Yeah, yeah.
So you know, you don't kind of feel your feet a lot these days. They're down there, but they need a bit of help, I think.
Yeah, well, it's important because you can do yourself a major mischief. You stand on something you shouldn't, simply because you can't feel what's going on. So if there are any ways of alleviating it to some degree, they're worth following up. Okay, any other topics?
Yeah, thanks.
Chapman, Ross hand has been up for a while.
Sorry, Ross, I missed you.
No problem. Thanks, Alan. A couple of comments, questions. Firstly, the issue around neuropathy is obviously pretty widespread, caused by chemotherapy or whatever. And I agree, Alan, that it's a connection between the vascus and the nervous system. And I get cold feet as well, and they go white in winter, and I wear bed socks. But it's definitely neuropathy, and it's caused by nerves. And the neurologist put me on Lyrica or pregabalin, and he said, "Oh, up to 4 tablets a day." I'm trying to wean myself off that because that for me is too much to have on top of everything else. But it certainly helped in terms of the pain, nervous pain, spasms, and those sorts of things in my legs. So I'm working on that one. I'm looking at lipoic acid. I'll certainly try that and listen to Gerald quickly. The other question I had is, I'm still on Luprin or Lucrin. Everyone's talking about Zoladex, which seems to be a replacement for Luprin, but I'm not sure. Does anyone know why one is better than the other one, or what's the?
I don't think they're materially different in their effect. They're both what you might call first generation ADT or androgen deprivation therapy. There's probably more people on Lucrin than there are on Zoladex because it came out earlier, but there's a lot of people on Zoladex as well. Diferoline is a little bit more recent, and you've heard the comments about there is some evidence that Diferoline is slightly more effective, at least in its durability of benefit. How material that is impossible to judge. Slightly easier in terms of the injection, as Jim mentioned. Yeah, I don't think there's a lot of juice in that area, really. There's a bit more in the anti-androgen category. So there are certainly personal responses vary between Zytiga and Xtandi and apalutamide and darolutamide. And to some degree, it's okay if you've got a side effect problem. For example, a lot of people have real fatigue issues with Xtandi. Some people even have seizures with Xtandi. Not many, but some. Definitely a drug-related effect. Yeah, just a matter of discussing the pros and cons of those with your medical oncologist.
Okay. Well, the issue around Lucrin, I actually asked the oncologist to go back from Firmagon. I got 2 monthly shots of Firmagon and hated it. Caused me all sorts of problems, just the injection of that massive amount in cutaneous injection. Caused me all sorts of problems. And I said, "I'll get rid of this, go back to the 3-monthly Lucan. I much prefer that." Does the same thing. He said, "So let's go." So yeah, that's good.
I should have mentioned Firmagon and the Garrelix. The good bit about that is that its effect is immediate. If you happen to have, for example, painful metastases, it will go straight to the source of that without having to wait for a month or whatever. So it's quick acting. But you're right about you get discomfort at the injection site. That's pretty universal. And I'll just plug my computer in before it goes off. Yeah, so, you know, I think Jim's used it for quite a long time. Jim, isn't that correct?
Yes. The problem I had with it, besides the pain, was that it also gives you sort of for the first few days after you have it, or a week or so. So you can feel pretty sick and miserable. The benefit, Alan's already said, it acts instantly and it's very solid. So the best recipe is to start with Firmagon, with the Garrelix, and then go on to one of the others. And as Alan says, triptorelin is very potent. I mean, that was particularly useful for me. You know, I missed one of my 3-monthly injections. I was hospitalised twice and sent off for a month of respite after that, and I missed a 3-monthly injection. But because I was on triptorelin, it just kept the PSA, so nothing went up. If I'd just been on Zoladex or even Firmagon, it probably, you know, the effect of holding it down wouldn't have been as good.
I think I just had one more comment to the, you know, the 3-monthly, even 6-monthly versions. These are delayed release or slow release capsules, in effect, which are injected either subcutaneous or into muscle, and they sort of hang about, gradually releasing their contents, or gradually decomposing, if you like, the film that's on the outside. And I know there's been a lot of comment about 84 days. I'm personally a little skeptical about that. I can't imagine that any of these preparations would suddenly fall off a cliff at the 84th day. What they will do is, as you approach 3 months, they'll gradually start to, you know, reduce, because there's less of it left there to dissipate. But you know, I wouldn't be losing too much sleep if you went to you know, 90 days instead of 84, for example. I doubt that you'd detect the difference. That's just a personal view. It's not anything I can add evidence for, but that 84 days has been around for a while, and I'm not by any means convinced by it.
So against that, there is evidence in this trial that I said Zoladex against the triptorelin, and the breakthroughs have been recorded. It's a personal view. It's one that Nev and I both share, because no, that's fair enough. The other thing is, all these drugs do the same thing. They take away your testosterone. So anybody who's worried about they're on one or the other or whatever, my preference for changing was because of the pain and feeling ill with the Garrelix, Firmagon. You'd only change if you have a particular worry about what you're on, especially if it's been working for some time.
Sure. Okay, so we're approaching the end of our allotted period. Does anyone else have anything that they wanted to ask or clarify or comment on before we close up. We're not putting any pressure on you to speak, but if you'd like to, now's the opportunity. Okay. Well, I think on that, we'll thank each of you for turning up. It's great to hear such a diverse range of experiences and opinion. Remembering that is all we're exchanging is opinion, that's valuable. So I'm not quite sure what the schedule is for our next meeting. Jim, do you have any idea?
I can help everybody by telling them I have no idea.
Okay. Well, we'll be communicating via Facebook and email. So once that's been sorted out, just keep an eye on it. We'll look forward to seeing you and hopefully some other newbies next time we meet. So,
Bye.
well,
Everyone stay well. Bye-bye.
Bye-bye.